السلام عليكم أبناء الطلبة. اليوم هنتكلم عن الأنسولين and the oral hypoglycemic drugs, or in another word, the drugs that are used for the treatment of diabetes mellitus. Before we talk about the drugs, we have to understand the background of this disease. The main organ associated with diabetes mellitus is the pancreas. This organ, the pancreas, produces peptide hormones including insulin, glucagon, and somatostatin. These hormones are secreted from different cells in the islets of Langerhans. The beta cells will produce insulin, alpha cells will produce glucagon, and delta cells will produce somatostatin. These hormones play an important role in regulating metabolic activities of the body, especially glucose homeostasis. If there is a lack or deficiency in insulin, as seen in diabetes mellitus, this will result in serious hyperglycemia. If this hyperglycemia is left untreated, it will damage or result in damage to the very important and sensitive organs in the body, such as the eye, causing retinopathy, the kidney, resulting in nephropathy, and the peripheral sensory nerves, resulting in neuropathy. If it is left untreated for longer time, cardiovascular complication may result. The administration of insulin preparations or other glucose-lowering agents, these will produce or reduce morbidity and mortality associated with diabetes. Diabetes complication can be divided in general into microvascular and macrovascular. The microvascular will include diabetic eye disease, as we said, retinopathy and cataract, renal diseases, nephropathy, neuropathy, peripheral sensory nerve ending damaging, and some food problems. While the macrovascular complications will include stroke, heart disease and hypertension, peripheral vascular diseases, and food problems. Diabetes mellitus is growing very rapidly worldwide. More than 400 million people worldwide are afflicted with diabetes. This is because diabetes is not a single disease. It is a heterogeneous group of syndromes characterized by elevated blood glucose and attributed to a relative or absolute deficiency of insulin. Changes in the dietary habits all over the world of many communities around the world have increased the incidence of diabetes mellitus. حتى تكون واضحة الصورة، الداء السكري في تصاعد في العالم كله، والسبب الرئيسي هو التغير الجذري والأساسي في الطباع المرتبطة بالتغذية، وهي تحسن المستوى المعاشي في كثير من دول العالم الثالث مثلا. بدأ الدايابيتس ينتشر أكثر بسبب تغير العادات في الأكل. لو أخذنا المنطقة العربية نلاحظ هناك زيادة هائلة في أعداد مرضى السكري في منطقة الخليج، وذلك بسبب الحياة الرقية والهادئة والتغير في نوعية الأكل وزيادة كمية المأكولات وخاصة من الكربوهيدرات، أدى إلى أن تكون نسبة مرضى السكري في منطقة الخليج بالمقارنة وهي النسبة العالمية مرتفعة جدا. أيضا في جنوب شرق آسيا وفي مناطق مثل الهند هناك تغير وتحسن في المستوى المعاشي، مما أدى إلى تغير في استهلاك كمية الكربوهيدرات في الغذاء وزيادة في السمنة، وبالنهاية زيادة في أعداد مرضى مرضى السكري. For the classification of diabetes, we have 4 classes. Type 1 diabetes, we used to call it before insulin-dependent diabetes mellitus, or type 1 diabetes nowadays. Type 2 diabetes, formerly we used to call it non-insulin dependent diabetes mellitus. Gestational diabetes, which is associated with pregnancy, and very rare cases of diabetes associated with genetic defect or sometime with the use of certain types of drugs. We'd like to make a comparison between type 1 and type 2 in relation to the age of onset. We usually see that type 1 starts at childhood or puberty, very early age, while type 2 usually starts at the age of 35 or over. Though nowadays we started to see cases at a lower age, and I mean in the 20s, among many people these days. Nutritional status at time of onset. Type 1, usually the patient is undernourished and very thin, while at the onset of the disease with type 2, the patient mostly is obese and overweight. Prevalence, 5 to 10% of all diagnosed diabetics are of type 1, while 90 to 95 diagnosed patients are of type 2. If there is any genetic relationship between the disease, parentalhood diseases and so on, the genetic predisposition with type 1 is moderate, but it is very strong in type 2, which means that if your parents are diabetic, it's most likely that you will be diabetic on the long run. What are the main defects seen with each type of diabetes? In type 1, the beta cells are totally destroyed and no production of insulin, while in type 2, there is inability of beta cells to produce appropriate quantities of insulin, and there might be also insulin resistance and other defects. Gestational diabetes is defined as carbohydrate intolerance with onset or first recognition during pregnancy. Uncontrolled gestational diabetes can lead to fetal macrosomia or abnormally large babies. Most of the patients with gestational diabetes will give delivery to large babies. And shoulder dystocia, which means difficult delivery due to the big size of the fetus, the delivery becomes uneasy. So mostly it is delivered through cesarean section. Hypoglycemia in the neonate is also seen. Well, diet and or insulin and exercise are effective in this condition. The main drugs used orally, glyburide and metformin, because they are not, let us say, toxic to the mother and the baby, can be used in addition to insulin therapy. In a normal post-absorptive period, constant beta cell secretion maintains low basal level of circulating insulin. This suppresses lipolysis, proteolysis, and glycogenolysis. A burst of insulin secretion usually occurs within 2 minutes after ingesting a meal in response to transient increase in circulating glucose and amino acid. This may last for up to 15 minutes, followed by what we call it postprandial secretion of insulin. However, without functional beta cells, those with type 1 diabetes can neither maintain basal secretion of insulin nor respond to variation in circulating glucose. If you look into this diagram, you could see here, this is the time we start infusion of glucose. And here is a patient with type 1 diabetes, the black line. The red line is type 2 diabetic patient, and the blue is a normal subject. If we see here, it is the plasma concentration of insulin, okay, and here is the time we start infusion of glucose. In the normal subject, what will happen? Insulin will be released after a very short time and with a high quantity, and then declines and start a basal level of insulin in the body. In type 1 diabetics, due to some deficiency in the beta cells activity, you could see that the red line is not a sharp one immediately after ingesting or infusion of glucose, but it is a slow increase in the level of insulin, which may last for some time. With type 1 diabetes, when there is a total deficiency of insulin, there is no peak to the level of insulin in plasma. Diabetes 2, main causes for that is lack of sensitivity of the target organs to insulin and lack of enough quantity of insulin secreted from the beta cells. In type 2, as we said, the pancreas retains some beta cell function, but insulin secretion is insufficient to maintain glucose homeostasis in the face of increasing peripheral insulin resistance. The beta cell mass may gradually decline over time in type 2 diabetes. In contrast to patients with type 1 diabetes, those with type 2 diabetes are often obese, which means they are overweight. Okay? Obesity contributes to insulin resistance, which is considered a major underlying defect in type 2 diabetes mellitus. The abdominal fat is one of the adipose tissues that is highly resistant to the insulin activity, which contributes mainly to the causes of diabetes type 2 patients. Treatment of diabetes mellitus. Type 1 diabetes must rely totally on exogenous insulin to control hyperglycemia and to avoid also ketoacidosis and maintain acceptable level of glycosylated hemoglobin HbA1c اللي احنا نسميه التراكمي اللي هو فد indicator للتغيرات اللي تحصل في مستوى السكر في الدم. Treatment of type 2 diabetes is mainly to maintain glucose level within normal limits and to prevent the development of long-term complication, as we have said before, micro and macro vascular complications. Weight reduction, exercise, and dietary modification decrease insulin resistance and may correct hyperglycemia in some patients with type 2 diabetes mellitus. Most patients require pharmacological intervention with oral glucose lowering agent in type 2 diabetes mellitus. Drugs used in treatment of diabetes include insulin, and we have different preparations of insulin. We have insulin aspart, insulin detamar, insulin glargine, insulin glulicine, and insulin lisipro. In addition to that, we have MPH insulin suspension, and we have regular insulin. Those that are already used, we have the sulfonylurea, which is the oldest group of drugs in the treatment of diabetes mellitus type 2. We have the glinides, ripaglinidine, natiglinidine, okay? We have biguanides, we have thiazolidine diones, and we have alpha-glucosidase inhibitor and dipeptidyl peptidase 4 inhibitors. We will talk about each group in depth in the coming slides. If we look into the insulin, let's say some few words about the history of insulin discovery. Insulin discovered by chance in the early 20th century when they did a surgical procedure to remove the pancreas of a dog. They found that the dog developed symptoms similar to type 1 diabetes mellitus. Okay, when the pancreas is homogenized and extracted, the extract, when injected into that dog, his condition has improved. So that was the first experiment on diabetes mellitus. When the pancreas been taken from animals and extracted, okay, uh, extracted the insulin from these pancreases and injected into patients with severe diabetes mellitus, their condition improved drastically. So that was the first connection between insulin, pancreas, and diabetes mellitus. Insulin in the past was obtained from edible animals from من الأغنام من الخنازير من الأبقار كان يؤخذ البنكرياس منها ويستخلص منها الأنسولين لذلك كان عندنا نوعين من أنواع الأنسولين نوع من الماشية الأغنام والأبقار ونوع من الخنازير كانت تستعمل. Nowadays, insulin is mainly obtained by genetic engineering, and we'll talk about this later on. Okay. In the body, insulin secretion is regulated by blood glucose levels and certain amino acids or other hormones and autonomic mediators. Beta receptors, alpha receptors, all these may interfere with the amount of insulin released. Secretion is mainly triggered by increased blood glucose, which is taken up by the glucose transporter into the beta cells of the pancreas. In the pancreas, in the beta cells, it is phosphorylated by glucokinase, which acts as glucose sensor. The products of glucose metabolism enter the mitochondrial respiratory chain and generate adenosine triphosphate. Any rise in ATP levels will cause a blockade of the potassium channels, leading to membrane depolarization and an influx of calcium ion. The increase in intracellular calcium ion will result in pulsatile insulin exocytosis. So insulin will be released. Exogenous insulin is administered to replace absent insulin secretion in type 1 diabetes or to supplement insufficient insulin secretion in type 2 diabetes. So we can conclude from this that exogenous insulin is useful in both types of diabetes mellitus, type 1 and type 2, but it is essential and basic in the treatment of diabetes 1. Pharmacokinetics and fate of insulin. Human insulin preparation is produced nowadays by recombinant DNA technology using strains of E. coli or yeast that are genetically altered or modified to contain the gene for human insulin. So when we say human insulin, it is not obtained from humans, it is mainly similar to human insulin but obtained by recombinant DNA technology. Modification of the amino acid sequence of a human insulin may produce insulins with different pharmacokinetic properties. Insulin preparation vary primarily in their onset and duration of activity. Dose, injection site, blood supply, temperature, and physical activity can also affect the onset and duration of various insulin preparation. Insulin is not taken orally because it is degraded in the GI tract. It is usually administered by subcutaneous route, and in cases of emergency, emergencies, we have regular soluble insulin, which can be given intravenously. Nowadays, there is a technique in which the insulin is subcutaneously infused, okay, and we call it the insulin pump, is another method of insulin delivery, which has proved to be very useful in controlling the disease, especially type 1 diabetes patients. Hypoglycemia is the most serious and common adverse effect of insulin. Other adverse reactions may include weight gain. The patient on insulin usually gain weight. There is some side effect seen in the site of injection, some kind of reaction, lipodystrophy we call it. Lipodystrophy is that at the site of injection of insulin, the layer of fat subcutaneously will be minimized or diminished. This will result in cosmetic say abnormality. نشوف نوع من الخسفة والانبعاج في منطقة بالسكن في منطقة الانجكشن. Diabetics with renal insufficiency may require a decrease in insulin dose. Well, the main symptoms caused by hypoglycemia, which we have to teach the patient about them, and so that he can be alerted to the side effect or adverse effect of hypoglycemia. Mainly, the main symptoms seen as headache, anxiety, tachycardia, confusion, vertigo, and diaphoresis أو التعرق الشديد. The patient may become shaky. The patient may feel very hungry, so the appetite is increased. May also show some severe weakness and fatigue. Vision is blurred, okay, and these two, let us say, symptoms or adverse effects are seen as lipodystrophy and hypersensitivity at the site of injection. If we look into the structure of insulin, insulin is made of basically from proinsulin. Proinsulin is the precursor for insulin, which is a long single chain of amino acids. To produce insulin, this is cleaved in the beta cells by disulfide linkage, as you see here, and here, and here, to form the alpha chain, A chain, beta B chain, and the C peptide chain of the insulin. Nowadays, the technology, biotechnology, has tried to change the sequence of amino acids at certain areas, okay, along this long chain of amino acids of insulin. This has resulted in different types or preparations of insulin with different onset and the duration of action. We'll talk about that later on. Here are the different insulin preparations. They differ mainly in what? Their onset, peak, and they differ in their duration. Okay, so the main difference between the different preparations of insulin is in the onset, duration mainly, and in the peak or maximum, let us say, plasma concentration. Insulin aspart, insulin lispro, insulin glulicine will have a very rapid onset and a short duration of action. The regular insulin, which is the soluble insulin, also have a short duration, short onset, but longer duration than the lispro aspartate, and glucose. The MPH, or the neutral insulin, has a slow onset and a longer duration of action. Insulin detamar has even slower onset of action but a longer duration seen. With insulin glargine, it has a slow onset but a continuous one level or one steady level or concentration of insulin without any peak. So, in general, we classify insulin preparation into three classes: rapid acting and short acting insulin preparation. We have the intermediate acting insulin, and we have the long acting insulin preparation. Let's see each one of these group. What are the main characteristics? Rapid acting and short acting insulin preparation, we have four preparations fall into this category: regular insulin, or sometimes we call it soluble insulin, insulin lispro, insulin aspartate, and insulin glucose. Regular insulin is a short acting soluble crystalline zinc insulin. Insulin lispro, aspartate, and glucose are classified as rapid acting insulin. Modification of the amino acid consequences, as we've seen in the figure before, on A or B chain produces analogs that are rapid acting insulin. This modification has resulted in more rapid absorption and a quicker onset and a shorter duration of action after subcutaneous injection. Rapid short-acting insulin mimic the prandial mealtime release of insulin to control postprandial glucose. We have two phases for glucose after meal. The mealtime, we call it prandial, and this occurs after 2 minutes of taking a meal, which lasts for about 15 minutes. And then after that, we have what we call it the postprandial glucose level. Okay, so the insulin needed here is a big burst of insulin or very rapid onset to control the prandial release, the prandial glucose level, and we need a sustained level of insulin to control the postprandial glucose level. Useful in cases where soft correction of elevated glucose is needed. Okay, so if you have a meal with plenty of sugars in it, okay, then you need rapidly acting insulin. Well, rapid and short acting insulin are usually used with longer acting basal insulin that provides control of fasting glucose. Regular insulin should be injected subcutaneously 30 minutes before a meal, whereas rapid acting insulin, as we said, the aspartate and glucine and so on, should be administered 15 minutes preceding a meal or within 15 to 20 minutes after starting a meal. Rapid-acting insulins are commonly used in external insulin pump, the one I just mentioned before, which is a pump that is sensitive to the variation in glucose level in plasma, and it pumps rapid-acting insulin in burst that controls the or normalizes the level of glucose in plasma. Okay. Regular insulin is most commonly used when the IV route is needed. It's more safe and more useful. The intermediate acting insulin, we have the neutral protamine agidorn or MPH insulin is an intermediate acting insulin formed by the addition of what? Of zinc and the protamine to regular insulin. So zinc and protamine will make the preparation turbid, which means that it is not immediately absorbed. It takes some time to be freed from this complex, zinc protamine insulin complex, and absorbed slowly. Another name for this preparation is insulin isophene. The combination with the protamine and, as we said, and zinc will form a complex that is less soluble and delayed the absorption and a longer duration of action. MPH insulin is used for basal, fasting, or postprandial control in type 1 or type 2 diabetes and is usually given along with rapid or short acting insulin for mealtime control. MPH insulin should be given only subcutaneously. Never use it intravenously, and it should not be used when rapid glucose lowering is needed because it takes time to reduce the level of glucose. And also, we do not use it in diabetic ketoacidosis. We need to use rapidly acting one. Long-acting insulin preparations, well, with insulin glargine, the isoelectric point of this preparation is lower than that of a human insulin, leading to formation of a precipitate at the injection site that releases insulin over an extended period of time. It has a slower onset than MPH insulin and a flat, prolonged hypoglycemic effect with no peak. Insulin detamer has a fatty acid side chain that enhances association to albumin. So there will be slow dissociation from albumin, resulting in longer acting properties similar to that of insulin glargine. As with MPH insulin, insulin glargine and insulin detamer are used for basal control and should only be administered subcutaneously. No intravenous administration. Neither long-acting insulin should be mixed in the same syringe with other insulin because doing so may alter the pharmacodynamic profile. So if we'd like to give two different types of insulin, we better do it in separate syringes. Insulin combination. Many of the commercial preparation in the market are a combination of regular insulin, soluble insulin, and MPH insulin, while the other preparations are usually available as pure preparation. So we have different preparations with different percentage of combination. We have the 70 and 30 percent preparation, and you have the 50 to 50 preparation of regular and MPH insulin. Premix combination decreases the number of daily injection, but makes it more difficult to adjust individual components of the insulin regimen. Nowadays, we hear these terms standard treatment and intensive treatment. What do you mean by this? You know, we have seen that on the long run, diabetes will result in complications. These complications, as we see in macro and micro complications, depends on the treatment schedule. The standard insulin therapy involves twice daily injection, while intensive treatment utilizes 3 or more injections daily with a frequent monitoring of blood glucose levels. So you could see that with the intensive treatment, we give more insulin and we may have the problem of hypoglycemia. Well, frequency of hypoglycemia episodes, coma, and seizure is higher with intensive insulin regimens. Patients on intensive therapy show a significant reduction in microvascular complication of diabetes, such as retinopathy, nephropathy, and neuropathy, compared to patients receiving standard care. Intensive therapy should not be recommended. It's serious, very dangerous for patients with long-standing diabetes, significant microvascular complication, advanced age, and those with hypoglycemic unawareness. They cannot really diagnose themselves or be aware of the hypoglycemia they suffer from. Intensive therapy has not been shown to significantly reduce macrovascular complication of diabetes, coronary artery disease, stroke, and peripheral arterial disease. Here is the diagram where we could see that the hypoglycemia episodes, you could see with intensive therapy, we have more episodes of hypoglycemia compared to standard therapy. But if we compare the percentage of patient with complication, you see with the standard, we have very high percentage of patients with complication. With intensive therapy, we have less percentage of patients with complication. So we have to balance it, and we have to be careful which patient should receive intensive therapy and which patient should go on standard therapy. Now we come to another injectable drug for the treatment of diabetes. We have the synthetic amylin analog. Amylin, what is amylin? Amylin is a hormone that is co-secreted with insulin from beta cells following food intake. What is the main function of this hormone? Is to delay gastric emptying. So it will decrease postprandial glucagon secretion and improve satiety. What do we mean by improving satiety? That the patient will feel هيحس شبعان فإذا ما حياكل أكثر لأنه المعدة مليانة لأنه تأخير في تفريغ المعدة إلى الأمعاء. Pramlintide is a synthetic amylin analog that is indicated as an adjunct موازي علاج موازي to mealtime insulin therapy in patients with type 1 and type 2 diabetes. Pramlintide is given subcutaneously immediately prior to meals. When it is initiated, the dose of mealtime insulin should be decreased by 50%. So you see, the use of pramlintide is a good way to decrease the amount of insulin consumed by the patient. Hypoglycemia should be avoided through the adjustment to insulin dose. Other adverse effects seen with pramlintide, that's nausea, anorexia, and vomiting. Pramlintide may not be mixed in the same syringe with insulin, and it should be avoided in patients with diabetes, gastroparesis, or delayed stomach emptying. Otherwise, it will cause severe delay in gastric emptying. We have to be careful about cortisol hypersensitivity and hypoglycemic unawareness in patients using amylin analogs. Incretin mimetics. Oral glucose results in higher secretion of insulin that occurs when an equal load of glucose is given intravenously. What does this mean? It means that when we take the glucose orally or with meal, okay, there are more than one system is sensitized. This effect we refer to it as the incretin effect and is markedly reduced in type 2 diabetes. The incretin effect occurs because the gut releases incretin hormones in the intestine, notably glucagon-like peptide 1. We call it GLP-1. And the glucose-dependent insulinotropic polypeptide in response to a meal. So incretin hormones are responsible for 60% to 70% of postprandial insulin secretion. What do we have? We have two drugs, exenatide and liraglutide, which are injectable incretin mimetics used for the treatment of type 2 diabetes. Well, if we look here, incretin or glucagon-like peptide 1 will result in stimulation of insulin release, inhibition of glucagon release, both will lower blood glucose. Incretin usually in the normal body situation, is inactivated by dipeptide peptidase 4 enzyme. Okay? We will come later on to a group of drugs that inhibit this enzyme and result in an increase in the duration and amount of incretin released by the GI tract, resulting in the same thing. So the GLP, incretin-like drugs, okay, like hormone, will actually function in this way. This DPP inhibitor drugs will function through the inhibition of this enzyme. Incretin is given by injection, but DPP4 inhibitors are oral drugs. So we'll talk about them when we talk about oral drugs. So incretin mimetics, mechanism of action is the incretin mimetics acting as GLP-1 receptor agonist. These agents improve glucose-dependent insulin secretion, slow gastric emptying time, reduce food intake by enhancing satiety or shaba, decrease postprandial glucagon secretion, and promote beta cell proliferation, the cathode beta cells in the pancreas. Consequently, weight gain and postprandial hyperglycemia are reduced and HbA1c levels decline. Pharmacokinetics of incretin mimetics, being a polypeptide, exenatide, and liraglutide must be administered subcutaneously. Okay? Liraglutide is highly protein bound and has a long half-life, allowing for once daily dosing without any regard to meals, while exenatide is eliminated mainly via glomerular filtration and has a much shorter half-life. Because of that, it has to be given, okay, in multiple doses, mainly twice daily within 6 minutes prior to morning and evening meals. Nowadays, we have a once weekly extended release preparation, and exenatide should be avoided in patients with severe renal impairment. Main adverse effects seen with incretin mimetics: nausea, vomiting, diarrhea, constipation, and pancreatitis. Pancreatitis is a serious condition. Liraglutide causes thyroid C cell tumor in rats, but does it cause this in human? We don't know exactly. Now we move to the drugs that are used orally for the treatment of diabetes mellitus. Oral antidiabetics are usually used only in type 2 diabetes mellitus. Patients who develop diabetes after age 40 or as we said, after the 30s, diabetes less than 5 years are most likely to respond well to oral glucose lowering agent. Patients with long-standing disease may require a combination of oral agents with or without insulin to control hyperglycemia. Oral agents vary in their duration and onset of action. Hypoglycemia is the main adverse effect. New agents may show other adverse effects, and we will talk about them individually, one after the other. Here is on the right side the different oral drugs with their duration of action seen. You see they have different duration of action, ranging between more than 24 hours to 2 hours, or even sometimes less than that. Well, here is a summary of the main adverse effect. With glinitis and sulfonylurea, we have hypoglycemia. With bigonides and alpha glucosidase inhibitors, we have gastrointestinal disturbances. With the DPP4 inhibitors, we have pancreatitis. With the bigonides, we have nausea. With the sulfonylurea, glinitis, and thiazolidinediones, we have weight gain. The most widely used group of oral hypoglycemic agent is the sulfonylureas. In this group of drugs, we have many compounds, and we have more than one generation. Many of the old first generation are no more in use nowadays. The available drugs in the market are mainly from the second generation. These drugs are classified as insulin secretagogues, which means drugs that increase insulin secretion because they promote insulin release from the beta cells of the pancreas. Okay. In Iraq, we have these four sulfonylurea, glyburide, glibizide, glympuride, and glibenclamide. Glibenclamide is widely used because it is recommended by the Ministry of Health for chronic disease patients with diabetes mellitus. Mechanism of action. The main mechanism of action includes stimulation of insulin release from the beta cells of the pancreas because the sulfonylureas drugs will block the ATP-sensitive potassium channel, resulting in depolarization, calcium ion influx, and insulin exocytosis. In addition, sulfonylureas may reduce hepatic glucose production and increase peripheral insulin sensitivity. The pharmacokinetics of these drugs. These drugs are orally administered. They are highly bound to serum proteins, metabolized by the liver, excreted in the urine and feces. The duration of action ranges from 12 to 24 hours. The main adverse effects seen with these drugs is weight gain, hyperinsulinemia, hypoglycemia, and they should be used with caution in patients with hepatic or renal insufficiency, since accumulation of sulfonylureas may result in severe hypoglycemia due to the increased amount of insulin released. Renal impairment may result in severe hypoglycemia, especially with glyburide, glibizide, or glympuride are safer options in renal dysfunction and in elderly patients. Glyburide has a minimal transfer across the placenta and may be an alternative to insulin or for diabetes in pregnancy, gestational diabetes. Due to its high plasma protein binding capacity, so we expect that drug-drug interaction is very common with these drugs. The second group of oral antidiabetic agent is the glinides. This class of agent is also considered as insulin secretagogues, which means they stimulate insulin secretion. Ripaglinide and latiglinide are the two drugs available. The mechanism of action of these drugs, they bind to a distinct site on the beta cells, closing ATP-sensitive potassium channels and initiating a series of reactions that result in the release of insulin. Glinide have a rapid onset but a short duration of action. So, they are particularly effective in the early release of insulin that occurs after a meal and are categorized as postprandial glucose regulator. Glinide should not be used in combination with sulfonylurea, which may increase the risk of serious hypoglycemia. The pharmacokinetics of glinides. Glinides are orally administered, should be taken prior to a meal, and they are well absorbed. Glinides are metabolized to inactive product by cytochrome P453A4 in the liver and are excreted through the bile. What are the main adverse effects? Well, the incidence of hypoglycemia and weight gain are low compared to that of sulfonylureas. A drug interaction may occur with drugs that are metabolized by the same isozyme CYP3A4. The concomitant use of gimfibrozil may significantly increase the effect of ripaglinide by inhibiting hepatic metabolism. Gemfibrozil is a drug used to control the level of triglycerides and cholesterol in plasma. Glenite should be used with caution in patients with hepatic impairment. The third group is the biguanides, and with the biguanides we have only one drug, and that is the metformin. This drug is an insulin sensitizer. The drugs that we have talked about are insulin secretagogues. They increase the secretion of insulin. This one increases the sensitivity to insulin, as insulin receptors. Okay, it increases glucose uptake and use by target tissues, decreasing insulin resistance. Unlike sulfonylurea, metformin does not promote insulin secretion. Hyperinsulinemia is not a problem. It has nothing to do with the insulin level. The risk of hypoglycemia is less than that with sulfonylurea. What is the main mechanism of action of biguanide? The main mechanism of action of metformin is a reduction of hepatic gluconeogenesis. So it reduces the conversion of glycogen into glucose. Metformin slows intestinal absorption of sugars and improves peripheral glucose uptake and utilization. So less glucose from meal will be absorbed by the intestine. Weight loss may occur because metformin causes loss of appetite, and that's why sometimes it is prescribed for patients with overweight to help them reduce body weight. It is recommended as the initial drug of choice for type 2 diabetes. Worldwide, most of the patients early diagnosed with type 2 diabetes mellitus are initiated with metformin. Metformin may be used alone or in combination with other oral agents or insulin. Hypoglycemia may occur when metformin is taken in combination with insulin or insulin secretagogues. So adjustment in dose for insulin and sulfonylurea, for example, is highly required. It may decrease the insulin resistance associated with polycystic ovary syndrome, may help in restoring ovulation, leading to pregnancy. I'd like to draw your attention that many of the gynecologists may prescribe metformin for ladies who have no diabetes mellitus. The main reason is that these patients have polycystic ovary syndrome, and metformin will help them restore ovulation and may help them to get pregnant again. Metformin is well absorbed orally, and it is not metabolized in the body and excreted unchanged in the urine. The main adverse effects seen with biguanides or metformin is gastrointestinal, mainly gastric upset, diarrhea, constipation, flatulence, contraindication in renal failure and in diseases that might lead to renal failure. There is risk of lactic acidosis, which may increase in presence of renal failure. Metformin should be used with caution in patients older than 8 years and in those with heart failure or alcohol abuse. Okay. Radiographic contrast, which is used in certain procedure of X-ray, okay, may, in the presence of metformin, may cause serious allergic reaction. So it is temporarily discontinued in such patients that will undergo procedures requiring IV radiographic contrast أو ما نسميه احنا بالأشعة الملونة. Rarely potentially fatal lactic acidosis has occurred. It is very, very rare condition, but it is possibly occurring in patients overusing the metformin. Long-term use may interfere with vitamin B12 absorption, so we have to have some kind of continuous check on hemoglobin level or vitamin B12 level in plasma. The thiazolidine is another group of drugs, okay, that are insulin sensitizer, similar to what? Similar to bigonad or metformin. We have two drugs here, pioglitazone and rosiglitazone. Although insulin is required for their action, the TZD do not promote its release from the beta cells. So hyperinsulinemia is not a risk. The mechanism of action here is different from other drugs. These drugs act as agonists for the peroxisome proliferator activated receptor gamma or PPAR gamma, nuclear hormone receptor. Activation of the PPAR gamma regulates the transcription of severe insulin responsive genes, resulting in increased insulin sensitivity in adipose tissue, in the liver, and in the skeletal muscle. These three tissues are the main site of storage of glucose in the form of glycogen. Rosiglitazone increases LDL cholesterol and triglyceride, whereas pioglitazone decreases triglyceride. Both drugs increase HDL cholesterol. These can be used as monotherapy alone or in combination with other glucose-lowering agents or insulin. The dose of insulin used in combination with these drugs have to be lowered and adjusted accordingly. Pioglitazone is recommended as a second or third line agent for type 2 diabetes mellitus. Rosiglitazone is less utilized due to certain concerns regarding cardiovascular effects. There are a lot of warning about the use of rosiglitazone these days, so its use is declining. Similar to metformin, these agents may also stimulate ovulation in polycystic ovary syndrome. The pharmacokinetic of this class of drugs are orally effective, extensively bound to serum albumin, metabolized by different CYP450 isozyme. Some metabolites of pioglitazone are pharmacologically active, mainly excreted by the bile and eliminated by the feces. Metabolites of rosiglitazone are primarily excreted in the urine. No dosage adjustment is required in renal impairment. These agents appear in the mother milk. So we have to be careful about breastfeeding mother, using these drugs. Main adverse effects are seen as liver toxicity. So we have to monitor the liver function. They cause weight gain. Because these drugs increase the amount of subcutaneous fat and sometimes cause fluid retention. Should be avoided in patients with severe heart failure. Osteopenia and increased fracture risk seen with patients using these drugs. Pioglitazone may also increase the risk of bladder cancer, a potential increased risk of myocardial infarction and death from cardiovascular causes are caused with rosiglitazone. So actually we have to use this class of drugs with caution. Another oral anti-diabetic agent is the alpha-glucosidase inhibitor. We have two drugs. We have acarbose and miglitol, used for the treatment of type 2 diabetes. What is alpha-glucosidase enzyme inhibitor? Let us see. First, alpha-glucosidase enzyme. What's the main function of this enzyme in the GI tract? In the GI tract, this enzyme breaks down carbohydrate into simple glucose or simple sugar. So it changes all the complex carbohydrate into simple sugars that can be absorbed. Acarbose and miglitol reversibly inhibits alpha-glucosidase enzyme. So it is reversible inhibition. Taking at the start of a meal, these drugs delay digestion of carbohydrate, resulting in lower postprandial glucose levels. They do not stimulate insulin release or increase insulin sensitivity. They do not cause hypoglycemia when used as monotherapy. When used with insulin secretagogues or insulin hypoglycemic or with insulin, hypoglycemia may develop simply because the amount of glucose absorbed is low, so we have to adjust the dose of insulin or insulin secretagogues. Should we give glucose orally to overcome hypoglycemia caused by alpha glucosidase enzyme inhibitor, and why? This is a question I would like you to think about because it might be homework for you. Garbose is poorly absorbed. It is metabolized primarily by intestinal bacteria, and some of the metabolites are absorbed but excreted into the urine. Xylitol is very well absorbed but has no systemic effect. It is excreted unchanged by the kidney. What are the main adverse effects of these two drugs? Major side effects are flatulence, diarrhea, and abdominal cramping. Adverse effects limit the use of these agents in clinical practice. Actually بالحقيقة كلش مزعجين كأدوية لكثير من المرضى لذلك استعمالهم محدود. Patient with inflammatory bowel disease or with colonic ulceration or intestinal obstruction should not use these drugs. Here we come back to the dipeptidyl peptidase enzyme. We have algoleptin, linagliptin, saxagliptin, and sitagliptin. All these are orally active dipeptidyl peptidase 4 enzyme inhibitors used for the treatment of type 2 diabetes. You remember the diagram we have? Okay, so we have the incretin, physiologically released, okay, in the body, and the DPP4 enzyme inactivates this. So these DPP inhibitors will inhibit this enzyme, and accordingly, the incretin or GLP-1 like drugs incretin released by the intestine will work for a longer time, resulting in stimulating insulin release, inhibiting glucagon release, and resulting in lowering of glucose level in plasma. So the DPP4 inhibitors may be used as monotherapy or in combination with sulfonylurea, with metformin, TZDs, or insulin. Unlike incretin mimetics, these drugs do not cause satiety, ما ينطون إحساس بالشبع or fullness, and are weight neutral. They do not interfere with body weight. Orally administered, food does not affect the extent of absorption. Allogliptin and sitagliptin are mostly excreted unchanged in the urine. Saxagliptin is metabolized to active metabolite. The primary route of elimination of saxagliptin and their metabolite is renal. Linagliptin is primarily eliminated via the enterohepatic system. All DPP4 inhibitors except linagliptin require dose adjustment in renal dysfunction. The most common adverse effect being nasopharyngitis, which is very strange, and headache. But the most serious side effect or adverse effect is pancreatitis. Strong inhibitor of CYP453A4 and 3A5, such as itraconazole, which is an antifungal agent, and clarithromycin, which is an antibiotic, may increase level of saxagliptin. The last group of drugs are sodium glucose cotransporter 2 inhibitors. We have canagliflozin and dapagliflozin. These two drugs works on the renal system, on the tubules. What is happening here? Usually, the sodium and the glucose is filtered into the tubular lumen, and then reabsorb. Sodium glucose cotransporter 2 is responsible for the reabsorption of the filtered glucose and sodium in the tubular lumen of the kidney. So, if we inhibit this cotransporter, what will happen? Filtered glucose and sodium will not be reabsorbed, and accordingly, this will result in more excretion of urinary excretion of glucose and sodium. So, the level of glucose in plasma will be reduced. So, using these drugs will result uh, in reduction of the amount of sodium and glucose reabsorbed into the circulation and will result in hypoglycemia. Of course, lowering the amount of sodium in plasma will result also in a reduction in the systolic blood pressure. But however, um, um, uh, this effect is not utilized for the treatment of hypertension. Pharmacokinetics, they are orally used as once daily in the morning. Canagliflozin should be taken before the first meal of the day, mainly metabolized by glucuronidation to inactive metabolite, while the primary route of excretion of canagliflozin is via the feces. About one-third of the dose is renally eliminated. These agents should be avoided in patients with renal dysfunction. The main adverse effect, especially in female, they may cause genitalial mycotic infections, vaginal candidiasis in female, urinary tract infection, and urinary frequency. Hypotension, particularly in the elderly or patient on diuretics, is widely seen. Now we have finished with all the drugs that are used for the management of diabetes mellitus, both injectable and oral. This table summarizes the main characteristics of all the groups that we have discussed for your summary of the main information about the drug. This is a diagram which shows you the steps we follow in the management of diabetes mellitus, uh, okay, which is recommended by the American Association of Diabetes. Thank you very much.